Good afternoon, everyone. Thank you so much for joining us today. My name is Sherry Munyon. I'm Director of Marketing for Bancroft NeuroRehab, and thank you so much for joining us this afternoon for our live stroke case study. I'm just going to go over a little bit of our agenda. In just a moment, I'm going to toss the baton over to Dr. Carolyn Lindgren, our Chief Clinical Officer. She's going to introduce our esteemed panel this afternoon and go over a little bit about Bancroft NeuroRehab and the Bancroft NeuroRehab difference. Then we will have an exclusive video that we're going to show this afternoon, and then we'll go into our live panel discussion, and we'll end today with a Q&A session and closing remarks. Dr. Lindgren?
Thank you, Sherry, and welcome everybody to the discussion. I'm so sorry we can't be together in person. I know that we're all looking forward to that day when we could get back together and have these meetings in person, but I really want to appreciate each of you for logging on and taking the time to talk with us. And I really want to give a thanks to the panel we have here who are really lending their expertise at points regarding rehabilitation. So just to introduce myself quickly, I am the Chief Clinical Officer at Bancroft, and I'm a neuropsychologist by trade. I have been with Bancroft for over 20 years. I am thrilled to welcome our panel. Of course, all of you on the call know Brian Propp, who is a Philadelphia Flyers legend here, and he's a 5-time NHL All-Star. Welcome, Brian. What you may or may not know is that in 2015, Brian suffered a massive stroke, and once stabilized and back on his road to recovery, he came to Bancroft NeuroRehab for treatment to help overcome remaining concerns with mobility and speech. And I just want to really, welcome him for sharing his story and being willing to discuss so openly his story. Because of who he is and his willingness to do this, he's deeply involved now at Bancroft NeuroRehab, both as an ambassador and as a board of trustees member, and has really lended his insight to that function. And so we're very glad to have him on board. Outside of Bancroft NeuroRehab, Brian serves as the Director of Strategic Relationships at Wolf Commercial Real Estate in Marlton, New Jersey. So welcome, Brian. I'd also like to introduce, I'm going to go in line, I think, of how you see us, Michelle Valente. Michelle, just give a wave. Say, yes, thank you. Michelle is a licensed speech language pathologist and a rehabilitation supervisor at Bancroft NeuroRehab. She has over 20 years of experience working with neurologic communication disorders and specializes in traumatic brain injury and stroke rehabilitation, both in inpatient and outpatient home care settings. Her master's degree is in speech language pathology from St. John's University, and she's an affiliate of the National Aphasia Association and a member of the Academy of Neurologic Communication Disorders and Sciences. So welcome, Michelle. Glad to have you on board. And then we're also welcoming Dr. Carolyn Tassini. Carolyn, can you give a wave? There you go. She's a board-certified physical therapist in neurologic physical therapy and a rehabilitation supervisor as well at Bancroft NeuroRehab. Prior to joining Bancroft, Dr. Tassini was the PT team leader of the Drucker Brain Injury Program at Moss Rehab, where she developed her specialty in TBI and stroke rehabilitation, vestibular rehabilitation, and Parkinson's disease. She completed her doctorate in physical therapy at Mass General Hospital. Currently, Dr. Tassini teaches TBI rehabilitation at Thomas Jefferson University and presents nationally and internationally on topics related to traumatic brain injury and anoxic brain injury. She's also the chair of the Brain Injury Special Interest Group for the American Physical Therapy Association. So welcome. So now I just really want to take a moment to introduce the video. Bancroft collaborated closely with Brian to produce this exclusive and moving video regarding his rehabilitation journey. It portrays the complexity of rehabilitation and the degree to which rehabilitation is both a clinical but a truly personal journey. So I'll turn the video over. What that video shows us and what Brian's story shows us is that rehabilitation isn't necessarily about the skill, the mobility skill or the cognitive skill or the speech skill. It's really about the person. And I loved what Michelle said at the end, that we provide the expertise, you provide the motivation. And I would say that Brian's probably the ideal example of that in terms of his positive attitude and the motivation. And that's why he serves as the ambassador for us and working with other folks who are due to stroke, because that's a key ingredient. So I just wanted to, before we get to our panel discussion, I want to share with you a little bit about Bancroft NeuroRehab. So what's rehabilitation about? First, it's about the structure of rehabilitation and the services that are offered. We offer a wide variety of services, a full continuum, everything from individual therapies to half-day and full-day programs to residential programs to meet the needs of anybody where they're at and the needs that they have at that time. In terms of the individual therapies we offer, as Carolyn mentioned, we have PT, OT, speech, cog rehab, neuropsychology, rehabilitation psychology. We offer vocational services. And the idea of this rehabilitation is to create a program that's more than the sum of its parts, to create a program that's focused on the individual's goals and the individual's desired outcome. So let me tell you a little bit about the team. The idea here is that the client is at the center of this 360-degree approach, where we work with, on the Bancroft team, we work with every stakeholder. We need to know the stakeholders' input and what they're expecting from rehab at the beginning of treatment. And then we need to work with the folks as a full team and not a series of individual therapies. So, for instance, walking outside may be more than just about managing your gait over uneven terrain. It may be about managing your anxiety as you step outside for the first time. It may be about being able to say hello to the people that you pass as you see them for the first time. It may be about making the decision about when you could step outside and under what circumstances it's safe to step outside. So if you come to a team that only works on the gait aspect, you're missing the full picture. Other piece is that we really need to know, what does the individual want for themselves? What does the family expect and hope for that individual? What are their hopes and dreams? And what are the funders' expectations for that person? We need to work with each of these stakeholders so that at the end of rehabilitation, we provide a very clear roadmap for folks. They get to their goals. At the end, everybody knew what was expected and everybody's satisfied. And so our other commitment is to really measure our outcomes and to measure our satisfaction. When some folks look at outcomes, they look at it from goals attained. We look at outcomes from every single perspective, from the family, the funder, person themselves, any of our staff and what they're expecting, what our accrediting bodies expect, and what our board of trustees expect. So we look at everything from goals attained to measurement on objective questionnaires that measure adaptability and skill, to quality of life, to depression and mood measures, all the way up to family, funder, and person served satisfaction, that we can be assured from each of those perspectives we're meeting the needs of what we need to do for rehabilitation. The other thing that makes us different is that we give our staff time to be thought leaders in the field, because that ultimately helps us raise the quality of service and helps the people we work with get the best possible service. So we have more board certified specialists. For instance, we have a board certified rehabilitation psychologist. A rehabilitation psychologist is someone who specializes in helping people adjust to physical changes or cognitive changes associated with neurologic changes or other illnesses. In New Jersey, there are 4 board certified rehabilitation neuropsychologists, and we have 1. We have more board certified. There are 18 in New Jersey. We have 2 going on 3 for our NeuroRehab line. Same thing for physical therapy. And Carolyn, I'm sorry, I don't know the number of board certified physical therapists in the state, but I believe we have at least 2, correct? Board certified.
We have 4 and in our program, and there are about 8.
So that's that level of expertise is a hallmark for people who are looking for our services, to know that we have for staff who meet the highest level of qualification. But beyond that, we encourage our staff to present at national, international throughout the year, and we support them by giving them time off to go do that. Our staff are adjunct professor at nearby universities. We have relationships with about 5 to 10 local universities, including Drexel, Widener, Thomas Jefferson, Rowan, and our staff teach there and train students from their professional schools in our program so that we can educate the future leaders in neurological rehabilitation. And then we have a 5-year strategic plan regarding research. And this enables us, excuse me, to be at the forefront of thought. So most recently, we partnered with Drexel University and are participating on a grant to evaluate the effectiveness of a virtual reality assessment of driving, return to driving after having a brain injury or stroke, which is a much needed service. And we're working right now with Cornell Medicine program in terms of a short-term adapted therapy strategy for mood following a brain injury or cognitive changes called the PATH program. So these are examples of how we lead the forefront in terms of new services and giving state-of-the-art treatment to everyone that we work with. Now we're going to switch over to the panel of the panel discussion, and I'm going to lead us on with a few questions to get us started. So the first question I have is a question for the team. What treatments does PT and speech language pathology use when it comes to rehabilitation? And Michelle, why don't I start off with you here?
Great. Hi, everyone. So speech therapy for stroke rehab varies depending on the client's needs. The first step is a speech language evaluation to determine which areas of function have been impacted by the stroke. A stroke may affect communication. There may be difficulty understanding or producing language, and that's called aphasia. There may be slurred speech and reduced overall speech intelligibility caused by weak muscles, and that's called dysarthria. There may be difficulty with motor programming for speech, and that's called apraxia. It may also impact cognition. So there may be difficulty in attention, memory, problem solving, and reasoning skills. That's often something, that we see. It may also impact swallowing. That's called dysphagia. There may be weakness and incoordination of muscles in the mouth and throat, causing problems swallowing, eating, and drinking. So based on the strengths and weaknesses that we find after the evaluation, we develop a treatment plan with the client. Once we've developed these client-centered goals, we then use evidence-based practices in therapy to work on those goals with them.
Thank you, Michelle. Carolyn, do you want to add some comments regarding PT?
Sure. So our, similar to speech therapy, our physical therapy, and actually our occupational therapy program as well, we're very patient-centered. So it starts with, what are the patient's goals and what are the challenges that they're having? What is it that they're not able to do in their life that they want to be able to do? And we'll do our evaluation and determine what are the contributing factors to that, develop a treatment plan in partnership with the patient and families if they if the families want to or need to be a part of that plan as well. So our treatment interventions will include things such as neuromuscular facilitation, so helping the motor systems, the muscles, learn how to work more normally and efficiently again. We'll work on strengthening. We'll do manual therapy for if we have muscle shortening, contractures. We really approach it very function-based. So we will do things like gait training and functional transfers and things to really help the person work towards that goal. We do have access to a body weight support system, so we can do high-intensity training with that on the treadmill or over ground. We can do different balance activities while in a safe environment. We provide a lot of education for our patients and our family members. And we really follow, there are some practice guidelines for different domains within stroke rehabilitation that we make sure we apply so we have the best evidence-based practice for all of our clients.
So you've both talked about a lot about some really highly specific therapies that are critical to stroke rehabilitation. What difference does a transdisciplinary team make? How is that an asset in neurorehabilitation?
The transdisciplinary team is critical, really. In physical therapy, we're oftentimes asking individuals to take risks and to do things that are scary for them. So if they have weakness in their leg and you're asking them to walk or take a step or move to a new environment like grass or outside or speed, that can be really nerve-wracking. And you know, having a team where you can call in your neuropsychologist to help provide support, or if you're working on some functional activities in physical therapy that could also be carried over in occupational therapy. So maybe some standing activities that it's to stand, it's another thing to fold your laundry, to cook a dinner. We can work in partnership with our other professionals in order to make sure that we're providing this comprehensive care for an individual.
And if I could just add to that, being a member of the transdisciplinary team really just benefits the patient's care overall. Therapy, if someone is suffering from aphasia and they're having trouble understanding, oftentimes physical therapy and occupational therapy want to provide some kind of home exercise program for the patient. And they're having difficulty, you know, figuring out what mode would work best with them. So we can help provide that input for them, and vice versa. If we're trying to get them to do something, a functional task at home, and we're really struggling, you know, on how to do that, we can look to OT and PT to help us. And having the psychology team is also such a great big plus for us, because if you could imagine, if someone suffers from aphasia and a communication breakdown with their family members, they're frustrated, the family is frustrated, and oftentimes we're able to refer them to them, but also get input that will help our treatment be more helpful to the client and family.
Thank you both. So my next question is Brian, and Brian, I mean, it's to everybody, the importance of skating in your life and the importance of physical rehabilitation, how important that would be for you. But could you comment on the importance of speech rehabilitation or cognitive rehabilitation in terms of your quality of life?
Yes, I mean, I still have aphasia. At the start of my stroke, I couldn't talk at all. The only thing I could say was and Bernie Propp. I don't know, it just came from me. But it took a long time for a speech therapist because I had to relearn with my brain how to talk. I'm doing much better now, and but it took a long time. So like just pictures and reading really made a difference, and being in front of people, not getting frustrated early, and slowing it down. Like my brain is still messed up a little bit, so I just have to take my time to get the words out, and sometimes the words don't come their way that I want, but I have people that are here to help, and so like they follow, you know, they'll cheer in and help me a little bit. But you know, it's you know, for speech therapy, it took me the longest, and but I was thankful that I had the NHL program that they were doing for cell-sem treatment, and I did that in January of 2017, and immediately I noticed a big difference with my speech. They took the cells from my hip and re-separated the blood, the three bloods, and then put the cells bad into my body. So I really noticed a big difference in improvement with my speech at that time. But I keep working it out. I go to a lot of events, and it helps me to talk with other people, just to get action and to stay the way that I am. So for me, it's really helped me, especially with my speech problem.
So that, you know, as you mentioned, you know, the frustration you felt early on, and a big part of speech therapy education, speech therapy treatment is education. Do you educate people about your aphasia when you meet them? How do you manage that when you first start working with someone or talking with someone?
Yeah, so I talk with a lot of people that have strokes and brain injuries, And when it happens, they're not sure what's going on with them, and they want to know how fast it can be healed and how it can help them to be positive and hopeful. And some people are frustrated at the start, and so like I tell them all the time, like you have to take your time. It takes your brain a long time to heal, and it'll keep getting better with the help that Bancroft gives all the people. And it could be specific to speech and physical therapy and occupational therapy. Like it really helps with me too. Like Carolyn really helped me with my stretching and with my fingers a little bit more. And the exercises that she did for me at home, I still work with them. And so that makes a big difference of my flexibility and the way that I'm doing. But the speech took the longest, but it's frustrating for people that, there's different kinds of speech that they have problem with. It could be mild or medium or strong. So I tell the people, hey, it takes time. You have to be patient with your body.
Well, that was, I'm glad you mentioned that, because that was actually going to be my next question for Michelle and for Carolyn. Rehabilitation takes time, and sometimes recovery or return to, there's not a full return to all of the skills that a person may have had. Clearly in Brian's case, his recovery has been really amazing. But in general, what's your advice to patients about the recovery process and the return to pre-injury functioning?
So I think one of the things that Brian touched on was people get frustrated, and I think it's really hard for someone to have a lot of patience with themselves and their recovery process. The stroke hits, and within seconds, minutes, your life has changed. And it takes much longer, as Brian is telling us, to make that recovery. So I think just helping them understand, helping them set realistic goals and kind of do it in steps. I think people want to see the big picture, so that could get them very frustrated. But if you break it down into little steps, take whatever the goal is. Like Brian's goal was public speaking, but he wasn't going to do that from the very beginning. He had to relearn words. He had to then put them in sentences. They had to make sense, and he had to be able to do that. But I think that also, Brian provides such great education because he still has some difficulty. He still has aphasia. It didn't go away completely, and yet he is still able to engage in these things. And I think that that's what's most important to show people and to share.
Yeah, I think, I think it's really important to recognize that, this is a process. It's not an immediate fix. And having worked in acute care and inpatient rehab and outpatient, the goals are always a little bit different, right? So if you're in acute care, when you work with clients there, they're happy to be alive. And then you're in rehab, inpatient rehab, and you just want to get home. And then you go to outpatient and you just want to be normal. And it's a struggle because, a lot of times there are ongoing deficits when you have a neurologic injury like a stroke. But what's really important is to learn how to have the most independence and the most quality of life with what you have. And I think Brian, he still has some of the language issues. He still has some challenges with his right hand, but he's able to go out. It doesn't stop him from, maybe modifying activities or doing what it is that he wants to do. And that's the key, is that it may not be the same, but you can still have a fantastic life, and it's going to take time. So from a rehab perspective, sometimes people think more, and we do do a lot. We do want to do more, but I think, we also have to recognize that there are times where you do some, and then you go and you live on your own, and you follow through, and you do your home exercise program, and you live your life, and then you come back because now I've done these things. I've trained. It takes a long time, and now I know I'm having these problems, and now you start the next round of therapy. And unfortunately, we do have funding restrictions these days, and that's a great way to kind of educate and also, empower people to get out there. And it's scary. Brian, you can probably, speak to what it's like the first few times when you've been discharged from services, and then it's like, oh gosh, now what do I do? And so we kind of have to help people, empower them to know that they can take those steps on their own.
So Brian, I do want to hear your answer to that, but I'm just curious, like, so how do you know when rehabilitation's over?
Well, I took my time at the beginning. Like, it took me like 6 weeks every day, 3 hours a day at the hospital, and then 5 days a week at outpatient. But the problem I had is that my occupational therapy lasted longer because, like, I needed the time to get better with my speech. My physical part was pretty easy because I was in good shape, and my occupational therapy still, needed some help from my fingers and my right side, but my speech took the longest, and so my insurance was really good from the NHL, so I could use it as much as I wanted it to, and so I went once a week after a year and a half, and then until the lady kicked me out because she didn't, I couldn't do as much as I want anymore, and I did as well as I could. But for me, it was easy because the NHL insurance is really good. But for a lot of these people, it takes some more time, and then they can figure out themselves when they have to get better. But I knew at that time, it was probably 3 weeks, like 3 months when I should have quit, but I still wanted to be every week and try to get better. So insurance made a difference, but for me it was I knew when I was ready to kind of go on my own, and but a lot of people don't have that luxury.
Right. So for Michelle and for Carolyn, like, when people meet their goals, how do you know for each individual person when the rehabilitation journey or when the outpatient rehabilitation piece is complete?
Well, it's a really tricky question. It's a really interesting question because, it's going to go on for a long time. And as you have an injury, maybe you have it a little bit younger, and then you get a little bit as you get older. There's normal aging things that may happen, and so those resources might be a little limited in your resources from a prior injury. So I think it's really looking at, those goals for that course of care, and then going and living, and then coming back and saying, I'm having these challenges now too. Right. So it's an ongoing process. It's hard to say when it's over, but I think our clients, when they, a lot of people will say it's never over until I'm perfect, and I think it's over. It will continue as the person until they're really living their life in a way that is, safe and functional and having some value and having value in what you're doing again.
Yeah, that is really a big challenge sometimes. I mean, sometimes it's very obvious when rehab is over and everybody's on the same page. You need some strategies. You may need some assistance. You may have some technology that might help you do that. We can help figure that out. And once we do, we want you to go out and live your life and use it. And then, like Carolyn said, if you have some other problems, come back to us. But I really feel like our people that are very successful are those that want to take that chance and do that. And sometimes it's hard to get them on that page, but with a lot of education and support, that's our goal. What you're saying it's not necessarily about the skill being completely back to baseline. It's about the person's quality of life being where they want it to be, and being able to participate meaningfully in the things that they want to participate in. And that's the goal of rehabilitation, right? Like, right. So that, a huge part of that is the person and what the person brings to rehabilitation. I mean, Michelle, you mentioned in the video we saw, Brian talked about in the video, the motivation, that individual motivation. I guess this is for Brian and for Michelle and Carolyn, the role of motivation and individual motivation in terms of meeting rehabilitation goals.
Well, for me, it was me getting back to skating. Thankfully, my balance was still okay. My both feet work, and I just have a problem with my right fingers and the right side. So getting back to skating was important for me, and golf, you know, because I love golf and fishing and all the things that I did. My one hand doesn't work that well, so I adjust. But to get back skating, it was so good for me because a group of guys that I skate with at Pennsauken Skate Zone, it's an invite only. We have 2 goalies each, full equipment, 5-on-5, games up to 5, and a couple subs. And so, but it's, you know why they're here, because it's invite only, and they're getting older, and so they don't want to get hurt. And but you know, I tell all the guys, you know, that I can still. We have the 2 goalies; they're not that good, and so I can still score every once in a while and do a couple of guffaws. So that made a much difference for me. But it's me, for the guys that know me, because another friend of mine, Nick Avgasti, had a stroke a year ago. And so like he come back skating now, but he's affected by it a little bit more. And so these are friends that I know and care about. But it takes time, and you're never the same after that. But it's giving them encouragement to be better, to do the exercises like Carolyn gave me at home. You have to keep up with it and try a little bit better, otherwise you lose it a little bit. But for me, hockey was great, and golf. You know, I can't hit the ball as far as I can anymore, but I usually hit it straight, and I have a lot of fun with people and make it fun. And then I went fishing this last couple of days, and I caught a keeper flounder in Seattle. So that's good, you know.
That's good. So you have a very clear motivation that moves you forward. For Carolyn and Michelle, do you see people need that clear motivation, or is it like, what are the qualities people bring to rehab that make it successful?
So I think just like, you know, with everybody, people have different motivation levels. Sometimes we have people that are highly motivated, you know, and they know, you know, what their goals are, and, you know, they're moving through the process. And then you have people that, you know, aren't so motivated to do things. It's just like, you know, normal. And we have to kind of find the things that are going to help motivate them. So, you know, sometimes, you know, it's a great time to have a transdisciplinary team, and, you know, family support, caregiver support, anyone. We have to work with them sometimes to say, hey, what's going to motivate this person for us to be able to meet these goals? And, you know, I think
motivation.
Yeah. And I think too, it depends on where they are in the process, early on, later on. You know, I think motivation kind of changes throughout the rehab process, and it's just something that the therapist and the team have to work with and help. But it certainly helps when someone is very motivated to be able to meet the goals and move them through the rehab process.
That's absolutely true. So if you think about, you know, your therapy is maybe an hour or 2, maybe 3 a week, you know, what are you doing in the rest of the time? And so I love, you know, that Brian's out playing golf and that he's skating, you know, that's
public speaking.
That's that public speaking, because he's out there he's exercising, he's engaging, his body's moving. And that's really important, and that's important to him. So that's why, you know, for us, it's really figuring out really early on in our care, what is it that motivates them? So maybe I think that what's important to someone is walking, but in reality, what's important to them is being able to pick up their grandchild or to go to the bathroom on their own. So we have to figure out what is it to them? What is it exactly to them that's important, and make sure that that's what we're addressing in our care. Because what we think is might be the value, it might surprise you what's really important to them.
Yeah, that's really true. Thank you.
And so that's a really big piece.
It is. And so that's the end of my questions. Stephanie, I'm going to turn it over to you to see the kind of questions that we're getting from the folks on the webinar.
First question is for Brian. Brian, as a public figure and speaker, did it make it any harder or easier to reach your therapy goals?
Well, it was tough because with aphasia, like you just had to take your time. But I got better and took my time and did some speaking. And then the more I spoke, the better I got. I got more comfortable with talking. And like right now, like it's doing really well. But for me, it was pretty easy at the start because I'm so active with things that I want to do. I want to get better all the time and take my time and just make sure that I'm doing it the right way, like we do at Bancroft.
So this question is for the team. How does stroke affect people at different stages of their life, such as young stroke? How can age play a factor in the overall success in rehab?
So it's Carolyn. So I think, you know, when we think about the age of an injury, the age that an injury occurs, the first thing is that everyone has things in their life that are important to them that they want to get back to. So, you know, when you're younger and you have an injury, maybe you have school, or maybe you're working a full-time job, and then as you're older, maybe your job, maybe, you know, your life responsibilities are more, you're retired and you're playing golf, or maybe you're caring for another family member, or you have a more sedentary life. So I think regardless, we're going to work with that individual to get back to whatever their goals were. So if it is to get back to school and to do those activities, that's what we need to address. And then, you know, as you're older and you just want to be able to go out and play with your grandkids, we'll work on that. Now, if we go neuroanatomy, you know, when people's brains are a little bit younger, they're a little bit more robust in their ability to recover from some of these injuries. So we call this neuroplasticity, so ability to make new motor connections. So some of our younger folks, we might be seeing some quicker recovery than in our older folks whose brains are a little less plastic, for you know, lack of a better term. But for the most part, it's really these individuals really helping them to achieve, maximize whatever it is in their life that it requires of them.
I think Carolyn did a great job answering that question. Not much more to add on my end from that.
This question is for Brian as well. Brian, do you ever return to Bancroft NeuroRehab for therapies to boost the goals you want to work on?
Yes, I've been at Bancroft with Carolyn a little bit more. Every once in a while, I need to work on a couple other things, and so she helps me. Like we did the video that we did for hockey, and so she helped me with doing push-ups and you know, stretching the shoulder and the hand, and so like but she does an awesome job with that, and I feel great every time she helps me with that. But for me, it's just like I'm at Bancroft. I work at Wolf Commercial, which is only 5 minutes away. And I usually stop every once in a while, but it's more of me about talking with the people at Bancroft, what's going on with their lives and how it can help them, just by listening to the other people that have problems. You know, I'm a good listener, and I connect with them, and they know that you know, they have problems too. But that's why our group talk this every month is going to be good for the people that have strokes and brain injury, because a lot of people need the help and want to talk about what happened to them.
The next question is for the team. Does funding matter? Does the rehab experience differ based on the referral source?
The experience doesn't change. The service provided does not change regardless of your funder. What is taken into consideration is that the plan of care, so the duration of time spent with an individual over, you know, that period of time, and therefore some of the goals might need to be considered. So if someone only has 30 visits for their year, we can either, you know, work with that individual and say, hey, we can do all this now, but then as the end of the year goes on, there's no more visits, or we can look at doing a shorter course of care to start, and then, you know, be able to have some visits later in the year if something should happen. But we do have to be very conscientious about what restrictions we have from an insurance perspective with respect to our planning our process. But the care will always be the same. So maybe the person has a loft, you know, work to get to that, but we might have to go here first before we can get to this one, given that we only have this time frame.
Michelle, is there anything you want to add?
It's something that isn't a secret. we know that day one, the client knows that day one, this is, what your benefit is. So that just helps structure our plan of care. We wouldn't do any treatment differently. We just might have, some time restraints on, meeting our goals. So we might make them, shorter term goals than something more lofty, to get them there. And then really provide some good home program, home instruction for them to continue doing that, outside of therapy.
I might add to that, I'm sorry, I was going to say, I might add to that, the source of funding matters in my experience, because it would also structure what the type of goal. So if you have a workers' comp funder, obviously you're going to be working on goals that are relevant to return to work, as opposed to a personal insurance, where you might be working on a quality of life or something more specific to the home setting, correct?
Mm-hmm. Yeah, I think it's a good opportunity, since of advocacy, because what we know about these neurologic injuries and what Brian's story is showing us is that people still make gains over years, and I think that's really important for funders to recognize, is that it's not just the first month or 6 months. It's years, and people, they're going to be living with this, and they're also going to be making changes. We're seeing that the evidence in the literature is showing us. And so I think that's a really important part for funders to understand.
The next question is for Brian. Brian, have you ever joined in on any aphasia group services?
No, I haven't, because I'm out most of the time, but I haven't joined one of those groups yet. Although I think that our talk at Bancroft that we just started could help with the people that have aphasia, not strokes and brain injuries too. So like it all kind of ties together. But I'm not a member of that. But at Bancroft we do a monthly call where people can see what they need help with.
That was actually one of my next questions that somebody had. So this one is for the team. How important is it to be involved in a support group after a stroke or a brain injury?
So I'll start off on this one. Personally, I think it's a wonderful opportunity and support to help get clients and family members through, depending on the type of structure of the group. What I have found in my experience is that not everybody is willing to give it a try, or maybe they're not ready to. I find early on after a stroke in the recovery process, they might not be ready to sit in a room and hear people talking about, it's been 2 years or it's been 3 years. Some people are fine with it, and others, aren't ready to hear that yet. So I think it really depends on the person's preference. I try to encourage people to really give it a try when I feel like it's ready for it's that time for them to do it. But it really can add such support. Hearing other people, like Brian's story, it can motivate people to do things that they may never have thought that they could do again. And it can form bonds, with other people. They can get together and do things for one another. Maybe someone drives and someone doesn't, and they can help each other out. I mean, it's really something I always try to get people involved in.
Yeah, I agree. I think, just that environment of knowing that you're not alone. You might think that you're the only one that's dealing with this, or that maybe there's something that you don't feel comfortable sharing with, your family or your friends or your therapist, but you realize you get in a room with someone else that you're thinking, you know what, they might have the same problem, and we can understand each other. And so there are support groups for patients and people that are survivors, and then there are support groups for family members, which I think is so helpful, because there are some family members that this is if someone's struggling a little bit more, that it's a big change on them, that their role may have also changed, that maybe they're now a caregiver, whereas before they were a partner. So I think they're fantastic.
So I know that when we did the Bancroft ball last year, I had 5 guys that had strokes and brain injuries. and a lot of them were retired or you know, were feeling better, but to give them a chance to talk amongst themselves and to figure out what they have to do, and for me it was good because I'm still connected with them. We talk with them all the time, but they need the help after rehab. They, you know, sometimes they don't know where to go back from there, but with Bancroft it really makes a big difference for making a list of people that I have, so that I keep in talking with them and say hello every once in a while to make a big difference and keep them with hope.
Thank you. That was a great discussion.
I want to close on a nice note. Carolyn and Michelle, can you share your most memorable moment of working with Brian and during rehab? It could be a funny moment, an impactful one.
Oh, Brian. You know, I think what really strikes me about Brian is that he's so dialed into what it is that he wants to work on. And I think that's a tremendous benefit, and that makes him, you know, really a joy to work with, because you know he's going to do what you tell him to do, or what you ask him to do, I should say. And you know that he's going to come back and, you know, and report on how that's going. So I think that's one of the things with me that I always enjoyed seeing him, because I always knew that he was going to do his program. I love working with athletes. You know, obviously he's a way different ball game of athlete, but you don't get to the level he did without having that competitive spirit and, you know, this focus on fitness and the focus on you know, improving himself. And so it was to see what he would do, and he would always try new things and activities, even if they seemed crazy. And the other thing about Brian was that he would always come in a golf shirt and pants, and always looking really a lot nicer than I ever did for therapy. So I thought that was kind of funny too.
I like listening to your trips too.
Oh yeah. No, we would share our little adventures, and
Yeah.
he got the award for best dressed patient.
So I met Brian, you know, much later after the stroke, you know, just a couple years back. And clearly he had made some significant, you know, gains in his language. And we really worked together during Facebook Lives, you know, and doing presentations together. His public speaking that he did for our clients at Bancroft NeuroRehab, like he's talked about. And I think that he always does such a great job, and kind of just looks to me like, you know, I did it. I got it. He doesn't really need much help anymore. And I think, you know, the thing about Brian is he's very aware, you know, that it still exists, and he's able to openly and freely talk about it, and to talk about aphasia. And I think a funny moment, Brian, that we had was when we were doing our Facebook Live, and you were like, I have aphasia, you can Google it. And I was like, no, I'm sitting right here, I can tell you what it is. And that's my moment with Brian, that we always, you know, when I see him, I look at him and he knows that's what I'm thinking, but yeah.
That's good.
Okay, I want to thank all of our panelists and all of you for tuning in to this. I really enjoyed the discussion with everyone. It's a pleasure to hear about the story in such a personal way, and to really understand how unique the rehabilitation experience is for everyone. So I want to thank you all, and I want to thank you all for tuning in.
Thank you.
Good job, girls.
Thank you.
Thank you, Brian.